Hello, everyone. This is Chadi Alraies from Cardiology Update. Thanks for joining us. This is another update coming to you from ESC 2024 that was just presented recently in London. I'm really today privileged to be with Dr. Mark Schuuring, who recently we published a video with him, kind of give us the prelim or the hypothesis behind this study. But now we have the fully published data as well as published paper about the same topic. The title Digital Consults in Heart Failure Care, a randomized control trial. Mark, thanks so much for being with us.
Thank you. Thank you for the invitation and happy to be back again.
Thank you. So, Mark, let's just remind our audience and listeners about the hypothesis of the study.
Yeah, so we have this hypothesis that there are 65 million patients with heart failure worldwide, and there's an increase in prevalence. And guideline-directed medical therapy, we know it improves prognosis, but it's underused. So how to implement the guidelines, that was what we were aiming for. So strategies targeting an increased GDMT use are thus of vital importance. And there were, before we started, some small non-randomized studies on various prescription intervention in heart failure patients and digital intervention studies in non-cardiac patients. So this was really brought up the idea to do that and to evaluate this in a multi-center randomized control trial.
That's great. Thank you so much. Again, just remind the audience, this is a randomized controlled trial, and we had the presentation before for the idea and the recruitment. So, Mark, this dives to the kind of method, how you did it, and the main findings.
Yeah, so the multi-center randomized control trial, 150 HFrEF patients, randomized 1-to-1. And yeah, as you mentioned before, the methods are described elsewhere in the paper, which is also open access available. The most important thing was the nudging to the clinician. So bringing back the information which was gathered from the patients with remote monitoring and from the previous history and brought back to the clinician. And there was a gap between this was prescribed on GDMT and this is what should be described. And this was brought back in the electronic health record to the clinician.
That's great. Now, let's go over the main finding and how we can implement this in clinical practice right now, especially with this cohort of patients with heart failure.
Yeah, so the primary outcome was a change in GDMT score, so guideline-directed medical therapy score in 12 weeks, and this consisted of class 1 indication therapy for HFrEF, and with equal weights. So there was a score between 0 and 6, which clinicians could get for prescribing the right medication. And we saw after 12 weeks a significant, statistically significant difference. So the prescriptions were better in the digital consult group than in the group with standard care. And that was statistically significant for iron screening and IV prescriptions, SGLT2 inhibitors, MRAs, beta blockers, and the switch to ARNI was a trend to significance, but that was, I think, underpowered in a larger randomized control trial that might have been significant as well, but we could not find that. And what we also saw was at 12 weeks, more patients were on optimal medical therapy. So more patients reach that point of optimal medical therapy in the digital consult arm. So that's really
great.
nice.
Yeah, absolutely. And this is, again, more contact with the patient. You are reminding them. But one thing kind of got my attention, maybe they should let the audience know about it, is the digital education that you use. Yeah, you mentioned in your paper that it's called patient education via text-based e-learning. Can you just elaborate that a little bit?
Yeah, so there was an e-learning. This was based on heartfailureMatters.org, so international heart failure website, and we brought that back to a Dutch version and a very concise method of delivering the e-learning right to the patients, tailored to what they really needed. So what is their disease? Why should they take the medication? and on fluid restriction and on salt restriction. And yeah, good to emphasize that we only needed a median of 3 summaries in a digital consult group to achieve this effect for the clinician. So this e-learning was brought to the patient did the measurements at home, and then was this summary created, and with a median of 3 summaries brought to the clinician, we got this effect.
Great. I mean, that's really, and in terms, was there any cost analysis done for this intervention that you did?
Not yet, so that's a very interesting question, and we'll definitely look at that. But what's interesting is we did not have more physical consults. So there was an equal number of physical consults and there was more remote contact. So yeah, actually there was an average per patient of 18 minutes, 18, spent by the healthcare team, by the research team. So that's doable. Like if you get a higher guideline-directed medical therapy prescription rates, and you expect in a larger trial also then have a reduced number of hospitalizations and reduced number of deaths, then you have your impact. That's yeah.
Perfect. But again, based on what I'm looking at, it doesn't look like it's a very expensive kind of intervention to be done, and which it speaks to the kind of can be implemented in a wide range in a very low cost, and especially the downstream winning, the patient not coming to the hospital, more compliant with the medication, and you're guaranteeing this patient on GDMT, and it's phenomenal intervention.
Yeah, thank you so much. And it's not just for heart failure. Like there's so many groups of patients who could benefit of these kind of strategies. So yeah, widely applicable.
Well, really, thank you again, Mark. Really appreciate you for having you for a second time. And thank you so much for and congratulations for a great study presented at ESC. And now Life will be happy to post a line also for the published that was just released on August 7th at Nature Medicine. Congratulations again. And thank you so much for your time. And for our audience, thank you for listening to us and being with us. Watch us on Facebook, LinkedIn, Instagram, and Twitter, or X now. And like us, and we'll see you in the next video. Thank you, Mark, for your time.
Thank you.